Hello to all of you lifelong learners and therapists dedicated to doing the best work possible. I'm Dr. Patricia Coughlin, clinical psychologist, and I focus on doing intensive short-term dynamic psychotherapy. And whether you do that particular model or not, I think a lot of the basic principles and techniques involved in this method can help you improve all of your work and enhance your outcomes. I'm going to be following up today on the video I posted last week about focus. And I'm going to be talking about that process of inquiry that really starts your work with the patient. Davenlu, who I trained with, focused on taking a very specific and phenomenological inquiry, focusing on the presenting problems, getting clarity about the nature, history, and severity of those presenting problems. And this is really the only kind of history he suggested we get. Not a general developmental history from the start, but really focusing in on why are you here? What is the pain? What are the problems that brought you to therapy? And particularly, what are those triggers? What was the precipitating event or incident that finally had the person pick up the phone? So you want to get a lot of specific information and a depth of understanding regarding these presenting problems. So that means that you as the therapist have to ask very specific questions, that you have to focus on phenomenology, right, which is really being, again, clear about how the problem is experienced internally, what kinds of problems it's causing in the patient's life. At the same time, you're going to be assessing the patient's strengths and capacities, their ability to articulate their problem, to answer your questions in a meaningful way, to collaborate with you or not. At this early stage, you're going to be encouraging the patient to be as specific as possible so that you can really understand them and help them. And the only defenses that you're going to focus on are those against that kind of specificity. You know, patients are often quite vague when they first come in. Well, I'm anxious all the time. Well, we know nothing is all the time, right? So we're going to have to, again, ask a lot of questions. Well, you say all the time, but well, let's just check in with you right now. Are you feeling anxious now? And how do you experience that? And how does that compare to other situations? Is it better or worse? What are some of those situations that would trigger a very high level of anxiety? And in fact, what happened recently that motivated you to call? So you have to keep asking those questions, being curious, open, listen, and then it turns out it's very important that you feed back to the patient what you're hearing. First of all, to make sure that you're understanding them right, they have a chance to correct you, and then also you can agree, okay, so this is how we're both understanding this problem. Very often I find that therapists are so anxious about, and I don't just mean anxious like neurotically anxious, but you know, they want to do a good job and they're so focused on trying to come up with an intervention or an answer in a sense that they're really not listening to the patient. It really interferes with that. And yet listening is one of the most important things, most important skills that you can hone, to listen deeply. And you're going to listen for those openings, those meaningful words, those slips of the tongue, those clues as to what's going on a deeper level. So I often say to my trainees, ask, don't tell. So you're not there to pontificate and tell the patient what to do. You're there to ask questions, listen deeply so the two of you together can understand both the nature of the presenting problems and to get a sense of what kinds of conflicts might be actually contributing to those problems. So specificity, phenomenology, listening, reiterating what you're hearing from the patient. All of this is going to help you do a much more effective inquiry and to get that agreement right up front about what kinds of problems you are there to address. I find all too often this is missing, and that therapists begin again to intervene too early. They make assumptions instead of really assessing. And it can be like 9 or 12 months into a treatment. And when they come to see me for supervision, I find out they never got really basic information that would shed light on the problem to be addressed. They're making big assumptions. So I can give you an example of someone who came to me for supervision. She was treating a 55-year-old man who was depressed and anxious, and in fact, so much so that he'd actually been hospitalized and then was being seen by her in an outpatient situation after the hospitalization. And she found out that this man would talk to his mother every day. And so she concluded that that was somehow the problem, that he was too close or dependent with his mother. So I have sort of a parallel in supervision to what I would suggest a therapist do with their patient, and that's that I ask a lot of questions. So I said, well, what makes you think that? I mean, has he always had this problem? He's always been anxious and depressed? And she said, well, no, actually, it's only been for about 3 years. And I said, well, so they've had that same relationship all his life. He's only been symptomatic for 3 years. So not likely that that's the cause. I mean, what happened 3 years ago? And even though she'd been treating him for 9 months, she had to confess she actually didn't know. So I said, well, you better go back and do that inquiry now. I really need to understand what was going on in your life at that time. What happened that precipitated this anxiety and depression? And then he told her his father had died. And actually, he had had a very complicated and competitive relationship with his father. And all of his feelings of anger and grief, had been completely suppressed and avoided. And he ended up in this crisis. But she didn't know that after 9 months. And so they could hardly then be focusing in on the feelings toward the father to help him resolve it. The good news is, doing the inquiry, at least at that point, did get them back on track. And it was interesting, I was talking to Jonathan Shedler, who's written all these wonderful articles on the effectiveness of dynamic psychotherapy. And he said he found also that in his supervisees, people who came because, again, they were stuck and needed help, that in 80% of the cases, it was because they never did a sufficient inquiry and they really hadn't deeply understood the nature of the patient's problem and hadn't ever agreed about what they were there to do. And the other 20% was some sort of countertransference problem. But this just all goes back to the importance of focus, specificity, and getting this agreement early on. Doing so is going to speed the process and make your treatments much more effective. So if this is helpful to you, please subscribe. Click on that bell, which will alert you whenever there's a new video. I'm committed to doing at least 1 post a week, sometimes 2. But September is going to be a very busy month for me with lots of trainings and also a big international conference, the IEDTA conference here in Boston. Actually, I'll have a link to that down in the description. So if you'd like to come and learn more about doing highly effective work with patients, that might really be a terrific way to deepen and expand your learning. Again, I'm totally open to all of your feedback and comments, what's been helpful, what else you might like to hear about. So let's keep the conversation going. Thanks.